Today we'll be talking about eclampsia. Now, we must know eclampsia is one of the most dreaded medical pregnancy-related emergency. One of the most ominous signs for the eclampsia is headache, convulsions, drowsiness, altered mental status, or coma. We must know that this eclampsia is basically a complication of severe pre-eclampsia. So how do we define this eclampsia? This eclampsia is like any new onset grand mal seizure or convulsions that is usually very commonly followed by altered mental status or coma. This typically occurs after 20 weeks of gestation, and it can occur up to 1.5 month of postpartum period also. So even it can occur even after delivery as well, and it can occur even in absence of hypertension or proteinuria. So most of the time, the patient will always have hypertension, pregnancy-related hypertension, but it is not compulsory to have hypertension. Even in 15 to 20% of the patients, patient may not at all have hypertension. So then what is preeclampsia? Preeclampsia is any female patient presenting with hypertension and proteinuria, especially after 20th week of gestation. We call it as the patient has preeclampsia. To label it as proteinuria, it should be more than 300 milligram per 24 hours. But nowadays, the eclampsia, to call it as eclampsia, we don't need to have the proteinuria as an absolute indication. This preeclampsia very commonly cause this fetal growth restriction, retardation. It causes reduced amniotic fluid. It causes abnormal fetal oxygenation. And obviously, eclampsia is one of the dreaded complications of preeclampsia. Also, the HELP, that is hemolysis, elevated liver enzymes, and low platelet count of less than 1 lakh. This is one of the very known complication of preeclampsia. Now we must know that this most eclampsia patients they present in third trimester only, and 80% of this eclampsia patients will have convulsions or seizure during delivery, during intraperiod time, or within 48 hours of delivery. After 48 hours, the risk of getting convulsion reduces markedly. But in so many patients, patient may still get convulsion even after delivery, up to 1.5 month after delivery as well. So it is very rare before 20 weeks, and it can rarely occur even up to 2 months after delivery as well. Now, there are some risk factors for eclampsia like nulliparity, family history of eclampsia, family history of preeclampsia, previous history of intrauterine growth retardation, abruptio placenta, fetal death, teen pregnancy, primary gravida. These are all well-known risk factor for eclampsia. Also, if the age is more than 35 years of age, if the patient has chronic hypertension, if the patient has a renal disorder or gestational diabetes mellitus, or if the patient has type 1 or type 2 diabetes mellitus, or if the patient has systemic lupus erythematosus or any autoimmune disorder, also these are very well-known risk factors for having eclampsia. Now, why this eclampsia is bad is because it can cause multi-organ involvement. In cardiovascular system, it can markedly raise systolic blood pressure. So it is associated with systolic as well as diastolic dysfunction. And during delivery, patient may have peripartum pulmonary edema. Patient may have heart failure, and patient may worsen significantly because of the cardiovascular involvement. Hematologically, it can cause so many problems like there is increased viscosity, there is endothelial damage, there is significant release of inflammatory markers in the blood. It can cause disseminated intravascular coagulation. There is marked hemoconcentration of the blood. There is marked increase in coagulopathy leading to DIC. Renal, it can significantly cause renal damage. Patient can have acute kidney injury, and patient can have reduced blood flow. Patient may need hemodialysis also if there is significantly reduced glomerular filtration rate. In hepatic involvement, there can be marked periportal necrosis. There can be extensive hepatocellular damage. Bilirubin very commonly rise, and there can be subcapsular hematoma also. In CNS, one of the most important thing is cerebral edema, cerebral hemorrhage, convulsions, altered mental status that can markedly complicate patient's management, and it can be very, very detrimental. Endothelial dysfunction can be one of the hallmark of this eclampsia, and it can cause diffuse damage of all the blood vessels supplying each and every organ. So it may damage kidney, brain, liver, muscles, tendons, nerve, eyes, everywhere. It can simulate DIC. It can land up in DIC. So hemolysis is very, very common. So patients very commonly present with anemia. On peripheral smear, because of this extensive endothelial dysfunction, we can see cystocytes, burst cells. Bilirubin of more than 1.2 milligram is very, very, very common. And platelet count of less than 1 lakh is extremely common. Because of the hemolysis, there can be marked increase in lactate dehydrogenase levels in the blood. What are the features of eclampsia? Seizure, definitely. Whenever we are calling eclampsia, it means we are talking about convulsion, altered mental status, seizure. So seizure is the hallmark of eclampsia. Headache is one of the most common symptom, and it can be seen in almost 80% of the patients. Patient may have edema, pedal edema, or periorbital edema because of the very commonly underlying increased plasma volume, increased blood volume, hypertension. Visual disturbances, these are very, very commonly seen in almost 40% of the patients. There can be vision defects, there can be photophobia, right upper quadrant pain, amnesia, poor mental capacity or altered mental status, or difficulty in concentration, papillary edema, and hyperreflexia. This can be very, very important features of eclampsia. Now, what is the treatment? The treatment for eclampsia, the definitive treatment is the delivery. Until you deliver the patient may have markedly increased risk of convulsions, multi-organ dysfunction, DIC, and both fetus and mother can be at risk. The medicinal treatment is magnesium sulfate. Magnesium sulfate is the best drug, and it is used for seizure prophylaxis in severe preeclampsia, or it is also used for controlling seizures in eclampsia. So if the patient has preeclampsia, then prophylactically magnesium sulfate is given, or if the patient has eclampsia, then it is given for controlling seizure. For blood pressure control, uh, so when it is about eclampsia, there are three things. First is delivery, second is magnesium sulfate, and third thing is blood pressure control. So blood pressure control can be definitely done by labetalol. It is available in injection as well as in per oral form. In injection form, it can be given by infusion. So 10 to 20 milligram of 10 to 20 milligram of labetalol can be given by infusion pump, and tablet form it can be given at the rate of 100 milligram 3 times a day, or it can be also given up to 200 milligram 3 times a day. But most of the time, if the patient is stable, if the patient has eclampsia, then the blood pressure control can be done with tablet labetalol by giving 100 milligram of labetalol every 8 hourly or 12 hourly. The second most important medicine for blood pressure control to prevent this eclampsia or to reduce the complication of eclampsia is nifedipine. So very commonly we give this nifedipine tablet 20 milligram 2 times a day or 3 times a day. Hydralazine by infusion pump by injectable form also can be given. Whenever there is seizure, then the injection magnesium sulfate is the drug of choice to control the seizure to prevent the recurrent seizures. The loading dose of magnesium sulfate is given. It's very, very important to give magnesium sulfate to any female pregnant patient after 20 weeks of gestation if presenting with convulsion. 4 to 6 gram of magnesium sulfate is given over 15 to 20 minutes, and 1 to 2 gram of this magnesium sulfate is given per hour as an infusion. The total 14 gram of loading dose has to be given to any female patient presenting with convulsions. And if the magnesium sulfate is not available, if infusion pump is not available by some for some reason, then 5 gram of magnesium sulfate is given in each buttock, so it will be total 10 grams, and 4 to 6 gram is given by IV route. If the patient has recurrent seizure or if the magnesium sulfate is contraindicated, in that scenario, injection lorazepam can be used. It has to be given 2 milligram per minute. It should not be given more than that per minute, otherwise it can cause respiratory depression. And it can be repeated it can be repeated after 5 to 10 minutes if the patient has a recurrent seizure. If lorazepam is not available, diazepam can be given 5 to 10 milligram slowly IV. It can cause very commonly thrombophlebitis. That is the reason why injection lorazepam is preferred over diazepam. So, whenever a patient is getting magnesium sulfate, definitely 14 gram has to be given. That is the rule because that is the loading dose, and most of the time it is always necessary, and you must give at least 14 gram of magnesium sulfate. After that, we have to keep checking the deep tendon reflexes, especially knee jerk, because if knee jerk they are absent, then it is an indication of stopping magnesium sulfate and checking magnesium levels to its therapeutic range. If they are normal, if the deep tendon reflexes are normal, then we can continue the magnesium sulfate, especially if the 14 gram loading dose is not given. Most of the time, giving 14 gram of this loading dose of injection magnesium sulfate is what is all required. After that, if the blood pressure is persistently high, then injection labetalol can be given by IV infusion as well. Especially if the blood pressure, systolic blood pressure is more than 160 and diastolic blood pressure is more than 110. Then 10 to 20 milligram of injection labetalol can be given every hour by infusion pump. Very rarely NTG may be needed, but most of the time it is never needed. And diuretics can be used if the patient has pulmonary edema or if the blood pressure is not controlled by above means. One of the most important thing is uh, uh, whenever we know that dyspnea eclampsia can cause significant fetal damage, significant fetal growth restriction. In those scenario, whenever the patient has one or more risk factors, so if the patient has one or more than one risk factors of this history of preeclampsia or multifetal gestation like twin or three fetuses, the patient has history of chronic hypertension or chronic hypertension, if the patient has gestational or pre-gestational diabetes 1 or type 2 diabetes mellitus or kidney disease or systemic lupus erythematosus or antiphospholipid and antibody, then aspirin should be or aspirin must be considered for a prophylaxis of pre-eclampsia prevention or eclampsia prevention to reduce the mortality, morbidity which is related to fetus as well as related to mother. Or if the patient must have more than one risk factors like nulliparity or obesity, having BMI of more than 30, family history of preeclampsia or lower income, social income status, or if the age is more than 35, or if the patient has in uh, IVF, history of IVF, then only this aspiration should be considered. So, yeah, even if one of this is present, aspirin must be considered, and there must be more than one risk factors among these, then aspirin should be considered. This aspirin low dose prophylaxis actually it helps in platelet aggregation inhibition. It markedly reduces the risk of vasospasm. It markedly reduces the preterm deliveries, and it also reduces the death, fetal death. And actually, it does not increase risk of placental abruption. So this was all about eclampsia and preeclampsia. So in short, any female patient presented with hypertension, proteinuria, that is eclampsia, and any patient with these things presented with convulsions, then that is eclampsia. That's all. Thank you.